Um, but just to kind of kick this off, so we had started this roundtable series at the start of the year, doing all of these in person. And I think even some of the folks on the call maybe have been at one or two of those, but obviously COVID threw a wrench in those plans. And we wanted to make sure we got them started back up, though, because we got great feedback from everybody. The goal, as I think Seth kind of mentioned, is for this to be interactive. We think there's a lot of power in bringing different people together to have discussions around these items. Obviously, Seth has deep background and knowledge in a lot of these areas, and so we want everybody to be able to bring any questions or issues or anything you might be dealing with in your business, and we'll certainly discuss our thoughts on it, and Seth in particular, but also anybody else that might have different solutions to those things. We want to encourage that interactive feedback. So we're going to focus today on, obviously there has been with COVID, there's a lot of uncertainty in the marketplace right now, not only around risk management in general, but also specifically what we're going to talk about today is the medical trends that we're looking at coming in 2021. And then what can you do as a business or business owner or human resources person to try to mitigate some of those trends that we're seeing. So we're going to talk through some of those strategies. And again, we want it to be interactive. If you've got a comment, a question, anything like that, please do not hesitate to throw it in that chat, raise your hand. We're going to go about 15 minutes, 20 minutes maybe on a conversation, or Seth will be walking through our thoughts around this, and then we'll open it up to a Q&A at the end. We're going to try to keep these over the course of time pretty efficient so that we, monitor everybody's time and such. But we do want to also, we have it scheduled for an hour. So if we are having a good conversation, we'll go the full 60 minutes with anybody. But with that, I do want to introduce Seth to those that may not know him. Seth is our chief strategist on our team. He is our market analyst and regularly is called by many of the major news networks to give his thoughts and take on the current state of healthcare, the trends we're seeing. He's also a best-selling author with his book, The Cure, A Blueprint for Solving America's Healthcare Crisis. And so he is deep in this industry and helping those making a lot of these high-level decisions, giving his advice and what we think should be coming. So we'll have a really robust conversation. But with that, Seth, I'll turn it over to you to kick it off.
Thanks, Elliot. I appreciate that. And I want to clarify one thing on the bestseller piece. So the way that the algorithms run for Amazon is that I think they're updated every like 20 minutes. So literally, if everybody on this call went and bought my book today, in 20 minutes, I would be the bestseller again. So it is one of those things where I was the bestseller for about 5 minutes, and then like the next hour, I was number, I don't know, like 472. So, but it still was a nice little tag. I got to, add to the book and all of that fun stuff. But nonetheless, it's good to be with everybody. I really do wish we were in person. I do enough news segments where I feel like sometimes I'm living a world in front of a camera, but I certainly would rather be in person. It's a lot more fun. I also actually feed off of audience participation, and it's kind of difficult when you're staring into a camera to get that. But nonetheless, it's good to be with everybody, and I'm really pleased to see how many people we had jump onto this, because I think that this is something that those that are engaged and informed will have an opportunity to find success, specifically around healthcare and their benefit plan in 2021. Hopefully you all brought your crystal balls with you and you're ready to predict the future alongside me as we talk today. Because I will tell you that right now, interestingly enough, is arguably one of the most difficult times to predict the future. And I'm not the only one saying that. Matter of fact, there's a report. Matter of fact, any of you that want this report, I'm happy to find a way to get a copy to you. We'll email it to you. It's only $59.95. I'm kidding. It's free. We'll send it to you after this call. This was a report that's done by PricewaterhouseCoopers every year. And I tend to follow this. I have super fun reading lists. This is a report on medical trend. And I will tell you that arguably PwC has done a phenomenal job over the past decade of predicting medical trend. Now, before I kind of dive into what this says, what I thought I would do is just kind of outline what trend is, just in case some people don't know. So trend is an industry word for inflation. But not inflation like we might think of the CPI, but inflation of what something that costs today will cost tomorrow in healthcare. So there's two types of trends that a lot of people need to focus on, though, when it comes to healthcare, and that is health insurance trend and healthcare trend, because those are two very different things. And from the health insurance trend, there's actually two branches of that, which is the reinsurance trend, which is for self-funded employers, and fully insured trend. So I'm going to break down those three things, and then we'll talk about the PwC report, and then we'll start talking about some of the things that you may be able to do to kind of offset some of that. So trend as it sits today in 2020 was set right about 5.7%. So effectively, if you had a $100 procedure done last year, in 2020, they would have projected that same procedure would cost you $105.70, right? I mean, that's just the way that it works. Now, understand that trend is a blended average of all medical expenditures. So it's not, hey, you know, like a flu shot may have been the same, but a hysterectomy might have inflated at 5.7% or actually inflated at 11.7%. And we've actually seen this movement over the last, I don't know, decade. And it really does fall in line with, I think, what we saw after the passage of the Affordable Care Act, that the big stuff, the big ticket items, that there's fewer things happening, fewer of these big ticket items provided, but they're bigger in numbers, are inflating at an astronomical rate, while the lower ticket items are deflating. So a flu shot didn't inflate 5.7%. It may have actually even deflated $2. Whereas, you know, a knee replacement or a kidney transplant could have inflated at 20 to 30%. Now, mind you, there's a whole lot more flu shots than there are kidney transplants. So it kind of balances itself out and the scales out. But why that's important is because in the United States, roughly 90% of all costs are generated by 6% of our population. So I'm going to say that again, 90% of all costs are generated by 6% of the population. And that statistic holds reasonably true in most companies, with more than 50% of Americans getting their health insurance from their employers and access to the healthcare system. If we were to break down the general data points in employer-sponsored health plans, we would find that same 6% to 10% is generating 90% of the costs. And so why that's important is and we'll get into this in a minute, is kind of as we start to think about how we really tackle costs and drive costs down, because at the end of the day, if I were to ask all of you the question of what is it that you really want out of your benefit plan, you're likely going to answer me with the same answer. You want better benefits at lower cost. Now, the way in which we get there, though, can be different for all of you, and the way in which the industry might tell you to accomplish that could be different as well. But I will tell you that unequivocally, there's only one way to get to lower costs, which will allow you to improve benefits. You reduce the number of claims that your people generate or the price of those claims. That's it. So, you know, shopping for a dumber underwriter doesn't do it. I'm a former underwriter, and I will tell you that the dumb ones are gone because I'm not an underwriter anymore, and they're all really smart, and they understand how to predict costs. And the health insurance industry is playing a game of chess while we're sitting around playing a game of checkers, and we're thinking 12 months in front of us. They're thinking 5 years ahead. And so they're highly capitalized, so they'll win the game unless you start playing chess as well. So the way that they win the game is by getting you to think improperly. Think about raising deductibles and asking more employees to pay more, and shopping insurance, jump insurance from United to Blue to Aetna to Cigna. I mean, you can go down the list. This is the shell game. This is getting you to think in checkers while they're playing chess and moving the pieces on the chessboard. And so you've got to think differently, and hopefully what we'll do today is start to help you do that. So back to trend. And why that matters is because, as I said a moment ago, if you want to reduce cost and improve the value of benefits, the only way to do that is to reduce the number of claims that your people consume or the price of those claims. So I'm going to put it in P&C terms. If you were thinking about your workers' compensation, for example, you would need to know what's going on if your mod started to rise, right? So you could put the right strategies in place, whether that's risk management or safety protocols or all of that. Your mod doesn't mean, let me say it this way. You shopping your workers' comp year over year doesn't do you a whole lot of good if your mod sucks. Right? I mean, you're still going to get back. Well, guess what? You have a health insurance mod. You do. You just don't know what it is. But I assure you, as a former underwriter, you do. And so part of what you need to start to understand is what that mod is so that you can start to manage it differently and improve it. And how do we do that? Well, we need to understand more of our data. We need to understand healthcare trends and how does that relate to health insurance trends. So Healthcare trend, again, 5.7% in 2020. We have seen that decline over the last, we'll call it decade and a half. In 2007, for example, healthcare trend averaged over almost 12%. Consistently for the decade prior. So we are seeing healthcare trend down. So again, I'm not getting into a political statement, but as people start to ask questions about was the Affordable Care Act impactful or not, there were some impactful things, although I would argue that there were very minimal ones. But one of those was in how healthcare trend has grown or not, for example. So we are seeing it about 5.7%. Now, some can equate that to the Affordable Care Act. I would actually equate it more to consolidation of the healthcare market and how dollars are getting moved around differently, but that's a conversation for another day. So 5.7% is healthcare trend in 2020. Now, let's equate that to what health insurance trend did. Health insurance trend in 2020 actually was about 9%, and it's been consistently 9 to 11% for the past decade. Now, why so much more? Why, if health insurance or health care delivery costs are going up 5%, are health insurance premiums going up almost double that? Profit. It's that simple. It's profit. It's the ability to maneuver dollars around and manage them differently. PBMs, and we won't get into all of the PBM, pharmacy benefit manager structure today, but these are ways in which insurance companies are able to generate more profit and pass along those inflated rates. The reinsurance market for self-funded employers is actually inflated at about 15% per year. And that obviously is very eye-opening, especially when you consider medical inflation at 5.7%. And so the reason it's 15%, and by the way, I would tell you that that's a pretty accurate number, is because, as I mentioned at the very beginning, the big ticket items are getting bigger while the small items are getting smaller. And so if you have reinsurance as part of your stop-loss policy in your self-funded plan, the reinsurer's claims that they're paying are the bigger claims. Okay, and so that's why 15% inflation on reinsurance premiums is actually pretty accurate across the country. The ways that we're seeing that deflated a little bit are if you're using a PBM, pharmacy benefit manager, that is part and parcel to the reinsurance carrier, although I can argue that that's a really bad strategy. It makes you feel good on the front end when you get your reinsurance renewal, but your actual claims fund is going to go off of the charts. So that's kind of where we are from a trend perspective. And so why is that important? Because it's important to understand a couple of key things. One is, this is quite literally the best time ever to try self-funding and to think about that. And the reason I say that is self-funding is scary, but self-funding is not self-insurance. Okay, self-insurance means that, hey, we're going it alone. And a lot of people, I think of self-funding as self-insurance, that, hey, we're going it alone. You're not. You have reinsurance, you have aggregate stop-loss, which caps your losses as a whole. There's a lot of components in that. So very few companies outside of 10, 20, 30,000 employees plus are self-insured. Most of them are self-funding, so they're funding a portion of those claims. And so that's why this is important, because if you are self-funding, you have the ability to curb that 9% fully insured trend. And you can curb that down to 5.7% or better if you will do some things differently and manage trend differently. If you are fully insured, you are likely subservient to that 9%. Okay? And I would argue that everybody is self-funded today. And what I mean by that is, even if you're fully insured, if you take a loss, trust me, the insurance companies aren't willing to take that loss for you. They will come calling and they will want their money back. Matter of fact, just this week, or last week actually, United Health Group, posted their largest second quarter, I think, in the last 5 years during COVID, which was interesting. $6.6 billion in profits for United Health Group. 16% inflated profit from Optum, which is their pharmacy benefit manager, the one that gets to set your formularies. And so why am I telling you this? Because in 2010, March 23rd, United Healthcare's stock price was $27 and some change. Today it's over $300. 1,000% markup. So this idea that the health insurance company is managing our money well is a bad one. It's a bad idea. They are managing your money well for them. And so it also helps us understand that everybody's self-funding. You're just self-funding to increase their bottom line or yours. And everybody's going to have bad years. So how do we manage that? So that's what I want us to talk about today a little bit. is how do we start to break that down and how to manage that differently? If we do go into a self-funded world, if you want to stay fully insured, that's perfectly fine. Just know that you're going to get what you get, no matter what anybody tells you. If you think about things long term, statistically based on averages, if you are spending $1 million in health insurance today, you will spend over the course of the next 10 years $15 million. The insurance companies know that. Remember, I said they're playing chess. So when they look at you and you're spending $1 million, they don't look at you and say, that's $1 million in premium. No, they think about it in $15 million increments. And so as we start to think about that, we need to start thinking about this as an asset and how we manage that differently than just, hey, a once-a-year transaction. Let me buy my insurance policy, hope for the best, and move forward. By the way, hope is a really crappy strategy when it comes to healthcare. And even if you self-fund, and I think that's why many people who have self-funded find it scary and or have had bad experiences because they used hope as a strategy. We self-funded and hoped we had good claims data. That's not a good strategy. You're going to have bad claims data. That's almost a given. Maybe not this year. You might get lucky. But people who get lucky for a short period of time. People who work hard, they get to reap the reward of that hard work for a long period of time. And so if you get lucky and you're fully insured, you help their bottom line. If you get lucky and you're self-funded, you help your bottom line. If you get unlucky and you're fully insured, they're going to ask for their money back so that they can help their bottom line. If you get unlucky and you're self-funded, you have the opportunity to not have that bad luck follow you for the rest of the decade. And so that's the big difference here as we need to think through this. And so going back to that idea of better benefits at lower cost, we have to understand that healthcare is a series of supply chain. If you've been on any of our talks before, you've heard us talk about that. But at the end of the day, we need to start thinking about how we get employees engaged at a higher level, utilizing the healthcare system when and where they need it. And so I'm going to break this down, and then we'll open it up to discussion. So there are 4 components to the healthcare supply chain. You have inpatient services, outpatient services, right? So inpatient being hospitals, outpatient being everything from outpatient surgical facilities to MRIs to CT scans to labs to physical therapy, you name it. It's pretty much everything that's not a physician service, which that's another quadrant, and then prescription drugs. And so, and much like the work comp world, if you had a high mod, you want to understand what's causing that so that you can think differently and strategically about how to manage that. You should be doing the same thing around healthcare. Where is your healthcare supply chain being utilized so that you can manage it differently? Because if we think about all of the basic networks, United Healthcare, Blue Cross, Aetna, Cigna, all of them, they're all pretty much in line with one another. Don't let them fool you and tell you that one is better than the other. It's really not more than a couple percentage points. And so the reality is, though, is within those networks, you have various pricing structures. So if you are a manufacturer and you buy, let's say, steel, and you have the opportunity to buy steel for, and I'm going to butcher this because I have no idea what the price of steel is, but let's just call it $100 a unit versus $1,000 a unit, you would be stupid to buy it at $1,000 a unit, wouldn't you? So why in the world, when your healthcare system and your healthcare plan is ultimately generating the dollars to pay the claims, would you ever buy an MRI for $5,000 when you can buy one for $500? Doesn't make any sense, does it? Yeah, we do it all the time. We give employees ID cards and tell them just make sure you go in network. But guess what? That $5,000 MRI is likely in network. And it's likely the one that most employees are going to because guess who tells them to go there? The doctor. And the vast majority of doctors are now owned by hospital systems. I think it was a recent Wall Street Journal report, showed that there is an average return on investment of 8 to 1 when a hospital system buys a primary care doctor because that becomes their sales force. That's where they're telling them to go, right? There's no money in the medical practice being a primary care doctor. I think Ryan Besmer's on the call. He could probably attest to that, right? There's very little margin in that. The margin comes in the stuff that you get sent to do. And the hospital systems know that. So again, remember, we're playing chess, right? And so we got to think about that. Where are people going to their doctors? And when they get told where to go to get an MRI, where are they going? So we need to start thinking about our health insurance outside the scope of deductibles and coinsurances and copays, and instead start thinking about it as where is my plan encouraging people to go to seek out lower cost and higher quality care? Where's the supply chain? Now, I'm not ever saying that we should create plans that say restrict access, but we should certainly create plans that incentivize better utilization of higher quality, lower cost facilities, right? So thinking about that differently and understanding your supply chain can help you do that. And in doing that, you can create more incentives that improve the quality of benefits, thus improving benefits while simultaneously lowering costs. You can buy a lot of $500 MRIs for one $5,000 MRI, can't you? And so again, thinking about it in those terms allows you to think differently about care. Recent studies showed that 80% of people said that they were loyal to their doctor and wherever their doctor tells them to go. In that same study, same people were asked, if we were able to show you facilities and physicians that were providing better quality at lower cost, would you change? The answer was unequivocally, the vast majority said yes. So they're not loyal. They're loyal because they don't know the difference. And so we need to allow the American consumer to be a better consumer. And by the way, consumer-driven healthcare doesn't do it. I'm a big fan of HSAs. I've been in one for 10 years. But the reality is HSA plans, as they are vastly utilized throughout the country, have created an unhealthier population and higher health insurance costs. Why? Because let's go back to what I said. 6% of your costs or population are generating 90% of your cost. Consumer-driven healthcare creates a barrier to entry for people to get lower cost healthcare. Remember, I said the spectrum of trend. The bigger ticket items are much more expensive than the lower ticket items. So that MRI at $500 that didn't get got because that patient had a $3,000 MRI and didn't know, that turns into an issue that becomes an $80,000 surgical claim. So I oftentimes refer to healthcare like the milk in the grocery store. Our health insurance system, in conjunction with the healthcare delivery system, has pushed the milk to the back of the grocery store. Where is milk in the grocery store? In the very back. Why? There's no margin in it. They want you to walk by all of the aisles of double-stuffed cookies that have a ton of margin before you get to the milk. Okay, I'm giving you some of my own demons, but nonetheless, here's the reality. If you want to lower the cost of healthcare in your home plan, you actually need to make healthcare more accessible and easier to get to. You need to move the milk to the front of the grocery store. Okay? And so how do you do that? You do that through strategic plan design. You do that through thinking differently. By the way, 6% of your population is meeting their deductible. 90% is not. So you raising the deductible $1,000 only does one thing. Pisses off the 90%. The 6% are going to hit it anyway. And so you're not saving money. You're just following into the lie of the health insurance industry that says, here's how we're going to lower cost. All that does is feed that 6% that the health care industry needs to generate more profit, and the health insurance company does too, because the health insurance company is just the finance company. All right? So again, thinking about that, let's start now, and we're going to open up to questions, but I want you to start thinking about why this is important to focus on now. Because medical trend in 2021 is what we call a WAG, a wild guess. All right? Nobody knows. Matter of fact, PwC's independent report says it could be as low as 4%, it could be as high as 11%. That's a pretty broad spectrum. They don't know. Why don't we know? Because of COVID. We don't know what COVID's going to do in the coming year. The average COVID claim can be anywhere between $20,000 and $120,000. That's a pretty wide average. And so don't let COVID, though, be your scare tactic into saying, oh, we can't do something creative about your plan. This is the opportunity to do something creative with your plan. To recoup some of those dollars and rethink differently. Those companies that are self-funded that we manage, for example, are doing really well this year. Because while everybody's been sitting at home not getting things done, they're not paying full boat health insurance premiums. You know why United Healthcare posted a $6.6 billion profit last quarter? You kept paying your health insurance premiums. You know why Blue Cross didn't post their profits? Because they're nonprofit. That's a joke. It actually is a real joke because they are nonprofit, and that's really sad. But nonetheless, all right. So hopefully I've kind of laid some groundwork for today's conversation. Let's open it up to some questions. Andrew, do we have any coming in?
Well, Seth, I was going to jump in while we had some folks thinking. Maybe talk through kind of a buzzword in the industry because you hit on it. Ryan Besmer's on the call as well. Direct primary care and what that is and how that might impact that healthcare supply chain and where that can be utilized, why it might be a good idea. Maybe just talk through some of that. And Ryan, if you have any feedback as well, jump in.
I'll say something. Maybe we'll unmute Ryan if he wants to add some color to this. So the doctor is the gateway to the supply chain, right? I don't wake up today and go, I think I'm going to go inpatient today at the local hospital. No, I go to my doctor who says, hey, you got a problem. We probably need to put you in the hospital, right? And so the doctor is the gateway to both manage care, to make sure we don't add more people to that 6%, and then make sure that 6% we're reducing the number of claims or the price of those claims, right? The hospital system knows this. As I mentioned earlier, the vast majority, I think it's now north of 70% of all primary care doctors in the United States are owned by hospital systems, okay? And so, as we said earlier, if you want to start bringing the milk to the grocery store, you going and telling your employees to do something, they ain't going to do it. That's just going to make them mad. They're going to think you're being overlordish and big brother and telling them what to do. But encouraging people through incentives to say, hey, we have identified doctors that are best in class, that want to engage in managing your care, not just for the 7 minutes that you're in their office, but actually for the entirety of time that you can be together and throughout the course of the care that you need, so much so that we will pay for that care. Well, that's a shocker, right? So telling employees, hey, we want to pay for you to go to the doctor. Unequivocally, unabashed, go. Direct primary care allows you to do that. And I will tell you, spending a little bit of money in that space will save you a lot of money over here, because a diabetic whose care is being managed appropriately by an engaged doctor is not going to become, or is likely to become, an amputee and have chronic major issues going forward. It can be more managed. Same thing can be said for heart conditions. Same thing can be said for as simple as things that happen when I hurt my ankle and I'm able to get into my doctor to find out what's going on so I can get to the right therapy or treatment, versus not going in and seeing my doctor because I can't get in, or I have this $3,000 deductible and I can't afford that MRI. So I don't get it done, and now I'm going to need surgery in 6 months. I mean, again, you can look at the overall statistics. So direct primary care is a great way to create an incentives-based program for your employees to go, if they want to see a doctor and fully engage. I will tell you, I'm part of a direct primary care platform myself, and I have a doctor who, quite literally, anytime I can pick up the phone and call, and they are phenomenal. And they'll walk me through whatever. They'll prescribe things for me if I need it. They know my family. They know my kids. They'll ask me questions. They're engaging, and it's a great relationship, and it's what healthcare is meant to be. And spending a small investment will yield massive results on the back end. Ryan, love to get your feedback or additional comments on that.
Yeah, thanks, Seth. This is Ryan Bessemer with Strata Healthcare. So we're a direct primary care company based out of Omaha, Nebraska, but we've got clinics in 5 states throughout the Midwest. And again, like Seth said, direct primary care is growing even before COVID, with this idea of companies saying, you know what, primary care is super important. It just doesn't need to be run through our insurance plan. And so instead, we're going to pay a physician a flat monthly fee per employee. And all the primary care is going to be handled in that clinic, and none of it is going to run through the health plan. An interesting point I just wanted to touch on, Seth. So you mentioned how during COVID, health plans are saving money, insurance companies are making money because people aren't accessing care. And I would just, an interesting tidbit of data from our end, we're seeing an increase of 2,000% in access to care through Strata Healthcare, and it's all virtual. But the nice thing is our clinics were set up for virtual care prior to COVID happening. And so, it's nice for these companies knowing that, okay, although my employees can't access care the way they were accessing it before, they can at least get it virtually from a doctor that they know. And so we're really passionate about this space. We absolutely love working with Seth. And any more questions about direct primary care, I'd be happy to field.
Yeah, I want to add to that too, because I think this is an important thing as we start to think about the COVID impact, and why I think that the trend models are very off is because, and we saw this as a concern, and many people said, oh, but we have Teladoc, we're okay. And don't get me wrong, I'm a big fan of Teladoc, but Teladoc is structured to really handle kind of acute cold, flu, sinus infection, stomach bug, ear infection, eye infection, those types of things. It is not meant to really manage diabetic care, chronic health care, heart conditions, all of that. Direct primary care is, because this is an engagement with that doctor. And so, again, whether you utilize direct primary care, or whether you really understand that you want to continue to use the model you're in now, you need to understand that every employee that is going to a hospital-owned doctor likely will cost you some money in the future. And so that's the reality of it. And the vast majority of employees are probably going to hospital-owned doctors because, quite frankly, There's 70% of them are hospital owned. So again, as we start to think about little things that we can do and little investments we can make that will yield high returns, direct primary care to me is one of the greatest, because again, if there's 4 components of the supply chain, that direct primary care doctor, or that doctor, whether it's direct primary care or not, is ultimately managing the other 4 components on your behalf. They're the gatekeeper to it. So you want to be rewarded in those other 3, which by the way are the big money being spent. Inpatient, outpatient, and prescription drugs, specialty drugs is a perfect example of that. Then that's a way to do it. Matter of fact, one of the things that I will say in this PwC report that I pulled out just to talk about, and again, we'll make sure we get a copy to anybody that wants it. This is the conclusion of PricewaterhouseCoopers report. And it said that there are really kind of what we'll call 4 key areas that they see that will not change as a result of COVID, that will actually be accelerated because they already were. One is mental health utilization. It was expected to rise before the pandemic. It is expected to explode after the pandemic. Why? Because people have been stuck at home. And that creates mental health issues and challenges and concerns. So and people that are needing help aren't getting it at the level that they need. So mental health utilization is going to expand according to PricewaterhouseCoopers. I would certainly concur with that. Specialty drug spending. So early on in my career, I've been in the business now almost 20 years, but early on in my career, it was a commonality that prescription drug costs was anywhere between 10 and 15% of the total healthcare spend within any company. That grew over time to be 20%. Today, it's over 30 on average, and it's expected to be over 40 in the next decade, if not higher. And for many companies that we look at, it is the vast majority of the cost, because specialty drugs are really, really expensive. Most employers don't realize that you can actually get access to specialty drugs for free. There are programs out there that are built to do that. The insurance company will never tell you that because they own the pharmacy benefit manager that distributes that drugs and gets a big chunk, in some cases up to 40% of the margin of that drug. So again, as we think about this, you've got to become smarter about how you're managing your plan. Because if I can get a specialty drug like, let's say, Humira, that is $6,000 for my employee for free, or run it through my health plan, which one sounds better to you? And so again, I'm going back to this. Utilizing a primary care doctor who understands these things will help navigate that system better. Telemedicine, as Ryan alluded to, telehealth or virtual health has exploded during the COVID crisis. Now, here's where we need it to continue to expand, is the things that Ryan was just mentioning, which is it's great that people who have cold, flu, sinus infection, stomach bug, ear infection, eye infection can get access to a doctor without going to a clinic when their kids get sick or something like that. Certainly that's a great thing. It's even better when the 6% of our population that's generating the vast majority of our cost is able to get access to that same care. In the traditional teledoc world, they can't. In the direct primary care world, they can. And then finally, they're looking to say that health insurers are going to start developing out more and more narrow networks. And they are. We're actually already seeing it. We're seeing it widespread throughout Nebraska right now, and narrow networks are a powerful thing. However, understand at the end of the day, who is building that narrow network and why? If the insurance company is doing it, they're ultimately doing it to impact their bottom line. And while there may be some opportunities for you to save money within that narrow network, if you do not have access to the data and understand it, what good is it? You may be feeding into their trap, so to speak. So I'm not saying I'm not a fan of narrow networks. I am more of a fan of a broader network with isolated, identified opportunity. So have the brevity of the entirety of the network, but identify within that network where people can go to get lower cost, higher quality care, and now you're managing the outcome, not United Healthcare, Blue Cross, Cigna, or Aetna. Any other questions that have come in? Elliot, are you anything you want to add? Or Brian?
No, and I haven't seen any other questions come in on the chat. I know that we've had a few people have had some audio issues with it being quiet, so we are recording this and we can get that out to watch as well. But yeah, any other questions anybody has, feel free to shoot them in. Or Ryan, I saw you unmute. Did you have something to add to that?
Yeah, I thought I'd just add this. If any of you out there are currently self-funding your health plan and you would like some type of an analysis on your claims, we can work with Seth, Strata can, to do a claims analysis to show you for all the different claims that your plan experienced over a certain given time period, which of those could have Strata absorbed in our clinic? How many people went to the emergency room for a headache or for stitches? And we can actually quantify that for you to show, okay, if you invest in primary care for your employees for unlimited access to primary care, how potentially could that pay off? So if that's interesting to any of you, let Seth know or Elliot know, and we'd be happy to work with them to do that.
Thanks, Ryan. And again, I want to make sure that we, again, direct primary care is one of those things that we're obviously very passionate about. It's coming through very loud and clear. What we're really passionate about is healthcare supply chain management and understanding that if you want to reduce the cost while simultaneously improving quality, you don't have to change what you're buying. You just have to change how you're buying it. You have to change how you're looking at it and thinking about it and working within it. And the days of just hoping for a better insurance renewal and launching into it they're over. I mean, they're not. You can still hope your outcome of what you're hoping for is not going to be positive. And so, again, there are employers out there, there are people out there that are doing some things differently and thinking about this differently. And by the way, in doing so, they're not reducing access. They're improving access. They're moving the milk to the front of the grocery store. We're not eliminating the broad network. We're showing the employees where they can go within that network to get better care at lower cost. We're building incentives within the plan to encourage that. And it's having a positive impact. We constantly track clients that are adopting these strategies. And by and large, these strategies are yielding lower costs year over year. So we can look back and trend. Our average client 5 years ago that started adopting these types of strategies, spending less today than they were 5 years ago. All the while, they're not raising deductibles or asking their employees to pay more. Matter of fact, they're doing the opposite. They're lowering the deductibles and asking their employees to pay less. But not doing so in the same way that we've constantly thought about it. We need to take the proverbial mindset that we've always lived in around deductibles, coinsurances, and copays and say this is the one-size-fits-all. And we need to blow that up and recognize that we can instead create a plan that says, hey, listen, you want to go anywhere you want in the network, here's your deductible. But if you go into these places within the network, your deductible can be lowered or in some cases eliminated. That saves you money because we're reducing your claims cost, and it improves the value of benefits because your employees can go, wow, I have options. I can go anywhere I want and have a deductible. I can go there and I not have a deductible or have a lower deductible. Guess where your employees will choose, by the way? Jeff Bezos has given us the blueprint to solve this, right? Employees, by and large, in every aspect of their economic lives, are good consumers. The average consumer in America spends 10 hours researching a car before making a purchase, 2 hours researching a flat-screen TV, but only 15 minutes on healthcare. They blindly trust anywhere that people in white lab coats tell them to go and go there. Why? Because they don't know the difference. We have to allow them to know the difference in a way that engages with them at their level. By the way, giving them a transparency tool won't do it. They won't use it. Less than 10% of all employees that have access to a transparency tool, pricing transparency tool, will utilize it. What will create an incentive or a utilization? Plan incentives and engagement. Engaging with the employee at the time of predetermination, engaging with that employee at the time where the doctor is telling them where to go, engaging with the doctor that's going to tell them to go where the lower cost, higher quality facilities are. These are the winning strategies that are yielding significant results. And so as you start to think about 2021 and beyond and how you're going to manage medical trend lower, that's the way to do it. I assure you Blue Cross and United and Aetna are not going to do it for you.
Hey, Seth, we did have a question come in that I think is perfect on that topic around direct primary care. So in small town Midwest, which we deal with a lot, how do you get to the 30% non-owned doctors without leaving town or having to go to Omaha or Lincoln or wherever? And thanks, Steve, for sending in the question.
Yeah, it's a great question, Steve. And Ryan, I'm going to invite you to answer that too. I will tell you that we take a very engaged approach when we're looking in what we'll call smaller markets or non-metro markets. And interestingly enough, sometimes I think they're easier because you have a very high level of engagement in doctors in those communities that want to do better for their communities. They're engaged in the community. They live in the community. They understand it. And so I'll tell you this quick story of we had this come up in Wapakoneta, Ohio, which is a very small town, who was convinced that they couldn't find a doctor or a DPC provider. And we were able to find one. And we found one that was arguably one of the best in town, phenomenal, wanted to engage with employees at a higher level. And we're having phenomenal results. And I'm sure that Ryan can give you example after example. We're having some of these same results. Ryan, you want to add to that?
Yeah, sure. So Strata, one piece of our business model is to work to expand our network, for lack of a better term, into areas to serve employer groups. So one of our clients is the state of Nebraska. State of Nebraska has employees all over the state. And so while we can't service every small town, we've done our best to contract with local independent primary care physicians to provide direct primary care as an affiliate of Strata Healthcare. And in fact, just this week, we are working with a doctor to set her up as a hybrid, like we call it, direct primary care physician in Durant, Iowa, population 2,000-ish. Because these physicians, while they don't love filing insurance claims the entire day to get paid, they also recognize that they can't just jump completely out of the system into direct primary care. And so we have a really cool model that allows them to operate in a hybrid way where they can support their community, support local employer groups, and get paid directly for services without having to file claims. And then on the flip side, the employer then gets to access that care for their employees and the cool cost savings model that Seth's talking about. So we have a really great system that we've worked out to start contracting with doctors and have those conversations with them. And that's primarily how we do it. However, there are some communities like South Dakota, it's a large community, but the state of South Dakota doesn't have a single direct primary care clinic because it is all owned by hospital systems. So there's certain areas that we just struggle in, but we're passionate about continuing to spread the word to get more doctors invigorated about primary care and doing it privately. So hopefully that answers your question.
Yeah, I'm going to add one thing to that because just kind of give you some background in it. So in 1992, if you remember, for those of you that know that time, that was Oregon Trail was the computer game that was all the rage back in those days. Disney's Aladdin, the cartoon version, I think was in the #1 movie that year. 1992, the United States healthcare system, by way of private pay insurers, adopted what's called RVU methodology, relative value units. This is a methodology that Medicare utilizes to reimburse doctors for the number of patients. And sadly, relative value units, or RVUs, are how they value the pricing structure of a patient seeing a primary care doctor. And the underlying thought, probably put together by a businessman in a suit and not a doctor, was that a doctor should be able to have 4 RVUs in an hour, one every 15 minutes. Now, that's not including the time that a doctor would need to maybe do some research, write notes, go to the bathroom, those types of things. And so the problem with that was, as hospital systems started buying more doctors and negotiating contracts with insurance companies, it was done so with the idea that they could see 4 patients an hour. Now, what does that mean for our healthcare? I oftentimes call it the 7-minute speed dating scenario than an engaged physician scenario, because that doctor, in essence, has 7 minutes to get out the door when they're talking to you, because that's the only way they can meet their RVU requirements, because they know they're going to have to spend a little bit more time with some patients. And so what direct primary care does, or an engaged doctor does, is it allows that doctor to do what, quite frankly, the vast majority of them want to do, which is treat their patient, to get to know them, to manage their care effectively. And so as we start to think about this, that's why so many people are either told, hey, here's a pill for your problem, or go to the 3rd floor to get an additional test done, because that allows that doctor to get out of that room in 7 minutes so they can continue to meet their RVU requirements. So engaging with a doctor allows us to get outside of that RVU basis, because, as Ryan mentioned, we're doing this outside of the insurance contract. Think of it like a capitation structure. And so it allows that doctor to do what they want to do, which is engage with their patient. Doctors hate RVUs, by the way. They absolutely hate them. because they didn't go to medical school to manage time. They went to medical school to be able to manage patients. But sadly, the business interaction has taken over.
Hey, Ryan, I'll ask you a follow-up question to that. How long is your average doctor visit with a patient, if you have any data on that?
I don't know that I could give you an exact stat on that, but I'll tell you, most of the time we're getting feedback from patients saying, I can't believe my doctor spent an hour with me. Most of our initial exams, we'll tell them in kind of an email that it's going to take 90 minutes just because we want to get a family history. We really want you to get established with your physician. And to Seth's point earlier, if you look at the stats on teledoc utilization, 1-800-TELEDOC, as I call it, it's not real high. And my theory behind that is that you don't know the doctor on the other end. And frankly, how good is direct primary care going to be with telemedicine attached to it if you don't know the doctor? So that first appointment and that relationship establishment is one of the most important components, I believe, to creating a valuable direct primary care setup. And because getting to know your doctor makes it that much easier if it's 7 o'clock on a Friday night and you think you have an infection in your toe and you don't know what to do. Well, gosh, I'll just text my doctor because I know him and he told me I could. So we like to say it's like having a doctor in the family. And I think the longer you can give patients initially and then never make them feel rushed in an appointment, the more likely they will be to see you as their partner in care. And then helping you to make those healthcare decisions that are in the best financial interest, for you. So.
Yeah, and so as we're kind of wrapping the conversation today, and obviously if you still have questions, we want you to send them in. We wanted this to be a roundtable, but we recognize we did one of these in person in Omaha. We've actually done them in Hastings as well, and we're getting a lot of engagement. It's difficult, I understand, on these virtual ones, but I understand we're spending a lot of time on direct primary care and that physician because in subsequent virtual roundtables or hopefully in-person roundtables, we'll talk about other supply chain components that you can manage. We start with the primary care one because, again, that's the key gatekeeper. And if you can solve for that, the other three areas of the supply chain become so much easier to tackle. If you can't, there's still ways to tackle those other three areas. And so in subsequent hopefully in-person roundtables, but possibly virtual, we'll talk about strategies of managing the prescription drug supply chain and how you can do that more effectively. Managing the inpatient supply chain and the outpatient supply chain, because each of those have varying components that in your health plan, you can actually structure ways to create incentives and better benefits while reducing costs. And we used to call that a unicorn. It's not. It's actually achievable. You just can't do it in the way that the insurance industry wants you to think you can. But there's a beautiful thing under ERISA, the Employee Retirement Income Securities Act, in which says that if you're an employer and you're providing benefits, you actually control your health plan. You get to make the decisions. Now, sadly, most employers don't realize that, and they forfeit their decision-making capabilities to Blue Cross, United, Cigna, and Aetna. But you have the ability, so long as you do one thing: don't discriminate. As long as you don't discriminate, ERISA pretty much says you can do whatever you want. Now, there's some caveats to the Affordable Care Act that we got to make sure we manage. But as long as we do those things, we can do pretty much whatever we want. We just have to find a way to build it out. And so, again, as you're thinking about the supply chain, there are those four components. In subsequent conversations, we're going to have more conversations around those other three components. But understand that we will always be including the primary care doctor, the physician within that, because, again, they are a critical piece to making sure you're managing it effectively.
Yeah, but we did have one last question before we hop off, probably directed at Ryan, but Ryan, can a DPC doctor make an income close to a doctor owned by a hospital, or how do you see that shake out?
Yeah, most direct primary care doctors with a full practice, and we consider a full practice to be 1,000 to 1,200 patients, which is, I don't know, Seth, what would you say, 25% of what they're used to caring for?
Yeah.
They can make 2-3 times as much as what they would make through a hospital system. We could talk more numbers if you'd like specifically, but it's a major selling point for us for doctors is you can spend more time with patients, have fewer on your panel, not have to file any insurance claims, and make 2 to 3 times as much money. It's amazing what the free market can do.
It really is, and I will tell you, I'll double down on that because it is amazing how many doctors are chomping at the bit to get to do this. And there's actually this, interestingly enough, there's almost like these, you remember chat rooms, right? There's almost like these websites where doctors can go and collaborate together. And it is a constant topic in these chat rooms conversations is, man, I wish I could just do a direct primary care practice or something like that. And the beauty of what we're trying to establish, or what we are establishing, what Strata is establishing for it, is this ability for doctors to be able to accomplish that in sometimes a crawl, walk, run methodology. But I'll echo what Ryan's saying. They're going to make more. They're going to have a better quality of life, and they're going to, really enjoy engaging with their patients. And the ability to have 1,000 patients versus, in some cases, 3,500 to 4,000 patients is powerful. And I don't know if you've experienced this. So my original doctor before I moved into this structure, I will tell you, is a personal friend of mine. I went to college with him, but he's owned by a hospital system. And if I needed to get in for my annual physical, it was 6 months to do that. And sadly, what finally ended it for me was when he had to cancel because he wasn't feeling well. And so when I called to get rescheduled, it was another 6 months. And so the ability to have, literally, as Ryan mentioned earlier, a doctor at the touch of your fingertips to engage is powerful. And these doctors love it. They actually love getting to know their patients.
Absolutely. Well, we appreciate those questions, Stephen. If anybody has any other questions, please don't hesitate to follow up with someone from our team. You can certainly, get back to me or Seth directly, but we'll make sure to get those answered and look forward to more of these types of format and roundtables in the future. We're hoping that we can continue with a format like this to get a lot of this information out and really give some strategies to be managing that trend that Seth talked about in 2021 and beyond. Because the world's changing, and we want to make sure that we're adapting to it as business owners and building in the strategies to make you successful. And so we'll continue to get invites out and make sure that everybody is aware of future events. But with that, Seth, I will close it out, and I appreciate the time. And anybody that has anything, follow up with us.
Thanks, guys.
Thanks, everybody.
Thanks, Seth.